I really thank everyone sparing such a evening time for interesting discussion on ARDS. This is my ICU, and I'm going to speak today on a management of ARDS. Next slide. Yeah, so I'm going to have a brief discussion on what is ARDS, what is the etiology of ARDS, what is the risk factor, something about the phenotypes, ventilatory management of ARDS, what is ventilator induced lung injury, and whether any drug which is having uh, beneficial effect when we are treating patient of ARDS. That is my agenda today. Next slide. So I'm going to start discussion with a case which presently we are having. I think we are discharging this patient today. This is a 52-year-old male was referred from Jalna to our MGM hospital with complaints of cough, fever, and breathlessness almost since 2 to 3 days. And he was from a village to went to a nursing home in Jalna, and he got admitted in Jalna ICU. And his breathlessness was increasing. He was having diabetes since almost 6 years on oral medication. He was chronic alcoholic, and last intake was 15 days back. And there was no history of similar kind of illness in past. He is non-smoker, and he recently attended a religious gathering 5 days back. So this is a brief history. Next slide. Next. So vital parameters, if you see, he has got tachycardia, blood pressure of 100 by 60. His oxygen saturation was 77 on oxygen with non-breathing mask at almost 50 liters of O2 per minute. He was tachypneic, was rate around 55 per minute. Bilateral lower zone crepitations. He was drowsy, arousable, and obeying commands. So that was a brief clinical history and finding on examination. If you see, these are the X-rays. This X-ray was taken at Jalna. You can see there are some bilateral shadows. This X-ray was taken in our ICU. And if you really wanted to investigate, even in Jalna, he was investigated. Next slide. So his throat swab was sent at Jalna and it was detected as H1N1 pneumonia. His COVID test was negative. Echo was also done and showing no regional wall motion abnormality, good LV injection fraction, no pulmonary hypertension, and having type 1 diastolic dysfunction. Next slide. And if you see, a CT scan was also done at Jalna, was showing clearly bilateral haziness in the both lung fits. Next slide. So I think with this clinical history, presentation, X-ray, CT scan finding, oxygen saturation low on even 50 liters per O2 by mask, it is clearly looking like a patient of community-acquired pneumonia with ARDS, isn't it? So this patient was put on NIV at Jalna and then was shifted in a ICU with NIV with 100% FiO2. Remember, any patient who is having such a typical picture of ARDS requiring high O2 in spite of NIV is tachypneic. So NIV is almost a very um, option of NIV should be taken very carefully. And shifting of this patient is also a challenge. We usually have good ICU ambulances with our team, which is very well experienced in shifting such patients. So our ambulance was um, sent to Jalna and patient was shifted on NIV. Sometimes we even intubate patient before taking to the ambulance and then we shift. But our doctors actually take decision at site whether to intubate before taking to ambulance or whether he will be shifted safely on NIV. So my doctor took a decision to shift this patient on NIV and this patient was admitted to our ICU. Next slide. So CAP H1N1 with ARDS. This is ABG on NIV. If you see, he was quite hypoxic in spite of 80% of FiO2 on NIV with almost PEEP of 8 to 10. And if you calculate PF ratio, PO to FiO2 ratio is less than 100. So it comes to a very severe kind of hypoxic respiratory failure. Next slide. So with this background, as I told you, what our clinical impression is, yes, it is a community acquired pneumonia, viral pneumonia, H1N1 with ARDS, and that to severe ARDS. So, what actions will take for this management of this patient? So, options are always starting oxygen with reservoir bag. Some may think of starting HFNC. Few might take option of non-invasive ventilation, and somebody might consider intubation in such patients. Next slide. So basically, ARDS is a major cause of morbidity and mortality in an intensive care unit. It is a life-threatening condition characterized by widespread inflammation of the lung, which leads to diffuse alveolar damage, surfactant dysfunction, abnormal coagulation, and activation of immune system that we all know. So it's a life-threatening and serious condition. It is not a particular disease, rather it is a clinical phenotype which may be triggered by various pathological etiologies. Next slide. It is interesting to know that in spite of such a clear picture, this is from data from the developed country. They did a epidemiological study of a large population, almost in the 15 countries, and what they reported that ARDS is still poorly recognized. Either it is delayed in diagnosis, or almost 40% time diagnosis of ARDS is missed for some reason. And so ARDS remains a unique heterogeneous syndrome with a different underlying cause and clinical presentation. Next slide. So, definition of ARDS. Actually, ARDS we know since almost more than 50 years, and there was first definition came in 1994, where European and American Society of Critical Care came together and they found a consensus definition. And almost after 1994, in 2012, this all expert realized that this ARDS and acute lung injury, which we initially used to define, is something confusing, and ALI is actually giving impression that we are dealing with something a mild disease, not like ARDS. So they excluded acute lung injury from a new definition, which was known as a Berlin definition, which is published in 2012. What the definition says about the ARDS? The timing of insult. So patient should have timing of 1 week of a known clinical insult or new or worsening respiratory symptom. Second criteria to diagnose ARDS is chest imaging, where the patient has got bilateral opacities which are not fully explained by effusions, lobar pneumonia, or lung collapse, or a nodule. Remember, effusion can mimic like bilateral effusion, particularly can mimic like ARDS, but it is not ARDS. So chest imaging. Third is origin of edema. We all know that we used to uh, consider ARDS as a non-cardiogenic pulmonary edema. So this origin of edema is respiratory failure, which is not fully explained by cardiac failure, explained by cardiac failure or fluid overload. So need to objectively assess a cardiac function either by echocardiography and exclude the hydrostatic edema if there is no risk factor. So we are sure by this criteria that we are not dealing with cardiogenic pulmonary edema. And third and most important criteria is a level of oxygenation. And depending on oxygenation, the ARDS is divided into mild, moderate, and severe. If our PO to FO2 ratio is less than 300 plus more than 200, it is a mild. It is between 100 to 200, it is moderate, and less than 100 PF ratio with PEEP or a CPAP, it's considered as a severe ARDS. As most of these patients are put on NIV or intubation, this new criteria, Berlin criteria, included PEEP in the PO to FO2 ratio, and now this definition is widely accepted. Next slide. But eventually, after COVID, lot of experts and societies realized that ABG is not available at all the parts of the country, particularly country like undeveloped countries or developing countries like us. So they actually considered a new criteria, that is hypoxemia is actually determined by saturation FiO2 ratio. So in this new global definition, which is published in 2023, they don't require ABG. If your SpO2 FiO2 ratio is less than 315, then even we can consider ARDS. And radiological features, if we don't have X-ray, we can even you take help of ultrasound to look for uh, lung condition, and we can diagnose mild, moderate, and severe ARDS. So this is a new change in ARDS guidelines, which is based on saturation rather than ABG. Next slide. So, for example, we can take a few patients like this male, 68-year-old, abdominal sepsis, septic shock, and having acute hypoxemic respiratory failure. This is the X-ray. He is mechanically ventilated with FiO2 of zero point 0.5 and PF ratio is less than 150. Intubated. So, with this criteria, X-ray, clinical presentation, and PF ratio, this is a moderate kind of ARDS because PF ratio is between 100 to 200. So typical patient uh, can diagnose ARDS prior to Berlin definition. Another lady, 54-year-old, history of breast cancer with COVID-19 pneumonia, worsening shortness of breath for last 6 days. X-ray showed bilateral shadows. Patient is on high flow oxygen, 40 liters per minute with FiO2 of zero point 0.8 and saturation 91. Without doing ABG, her saturation to FiO2 ratio is 114. So with new category of global definition without in non-intubated patient, this patient also comes as a ARDS. One more example is that 39-year-old female with abdominal sepsis having gram-negative bacteremia in a small unresourced hospital without blood gases and even radiological limitations or mechanical ventilation. So if you see the ultrasound has been done, which shows B lines. Patient is on supplemental oxygen of zero point 0.6 and SF ratio is 142. So again, this patient is having ARDS in a resource limited setting. So we can diagnose ARDS on clinical ground without having ABG in hand. So this is a new change, particularly in a resource limited setting, uh, global definition of ARDS 2023. Next slide. So many patients can have a similar kind of a syndrome called as ARDS. But if you look at the history of ARDS, some patients having a state of shock, then hemodynamic instability, pulmonary derangement, and levels of inflammatory cytokines are very high. And few patients actually having difference in the mortality. Some patient may respond good to PIP. Some patient actually respond to simvastatin and fluid strategy, and some patient may not. So this is called as ARDS phenotype. Some are hypoinflammatory, where the interleukins are not very high, and some are hyperinflammatory phenotypes. And people are now looking for subphenotypes of this ARDS patients to find out a very effective treatment for a precise care or precise management of ARDS patient. So some patient may benefit with XYZ treatment or XYZ drug, and people are now looking for very precision in phenotyping of this patient, and research is moving towards ARDS phenotypes and uh, phenotype based management to this patient. Next slide. So this is a patient where hypoinflammatory subphenotype where interleukins are low. They have got less mortality and increased ventilator free days. And some are hyperinflammatory phenotypes where there is high mortality, decreased ventilator free days, and these interleukins are very high, bicarb is low. So these are the examples of hypo and hyperinflammatory subphenotypes of ARDS. Next slide. So, as we all know, what are the common risk factors for developing ARDS? There are some direct injury to the lungs, which includes pneumonia, either bacterial, viral pneumonia, community acquired pneumonia, or hospital acquired or ventilator pneumonia, aspiration of gastric content, sometimes inhalation of uh, toxic agents, pulmonary contusion, pulmonary vasculitis, and even drowning can cause direct lung injury and direct uh, direct injury will cause ARDS, and sometimes you may get indirect kind of a ARDS where patient may got non-pulmonary sepsis, maybe abdominal sepsis. We may get ARDS in patients of dengue, uh, malaria. Uh, so commonly in patients of dengue and malaria, we get ARDS. So there's a non-pulmonary kind of ARDS. Major trauma can lead to ARDS. Pancreatitis, burns, patient with non-cardiogenic shock, drug overdose, and even multiple blood transfusions or transfusion-induced lung injury can lead to ARDS, and these are called as indirect causes of ARDS. And we all know mechanical ventilation, which is a age-old therapy since last almost 100 years, is a life-saving treatment. And with advent of knowledge and experience and a lot of studies, we know that mechanical ventilation, though it is life-saving, may cause some secondary injury, and it is called as ventilator-induced lung injury. So remember, though it is a standard therapy of intubating this patient and ventilating this patient, if you don't into ventilate this patient with a lot of care, a lot of guidelines, we may actually induce lung injury and patient may worsen. So when we think of modalities of ventilation or oxygenation, we have non-invasive ventilation, high flow nasal cannula, or intubation and ventilation. So which modality is best? That is a big question. Next slide. Since COVID, we are having a lot of experience in using high flow and NIV. Look this picture. This is a picture of a animal which is normal lung. This slightly inflated and reddish lung is after 5 minutes of ventilation, and after 20 minutes, see how lung is looking like an angry lung. So this is actually a injury caused by inadvertent or high tidal volume lung ventilation. So this is just to show that mechanical ventilation can cause lung injury. Next slide. So remember, NIV is not a very standard and proven technique to manage ARDS. A study of patient with hypoxic respiratory failure, there's an increase reported an increased mortality in association with NIV when compared to patient treated with high flow nasal cannula. So NIV as compared to high flow nasal cannula is more risky to the patient than high flow. Use of NIV in patient with severe ARDS when PF ratio is less than 150 was independent predictor of mortality. Type of mask also matters, and it is been found that if we use helmet mask is better than whatever we using oronasal or facial mask. But remember, more NIV failure and higher mortality is found in ARDS patients. So when you are using NIV, be careful. You may have to intubate patient early. We can try NIV in very few patients of ARDS where patient is having mild ARDS and maybe extrapulmonary ARDS. But remember, if you start NIV and patient is not settling in couple of hours, if his FID requirement is very high, he's tachypnic, he's exhausting, he's having other comorbidities, it is better to intubate rather than waiting for a delaying intubation. Next slide. So this is again a warning that use of NIV in this lung study, lung safe study show that use of NIV in patient with severe ARDS when PF ratio is less than 150 is independent predictor of mortality. So data is also not in favor of non-invasive ventilation. Next slide. So since almost 2004 to 5, after this landmark study published in New England Journal of Medicine about the low tidal volume ventilation, we all started using low tidal volume ventilation, or it is called a lung protective ventilation strategy. And this actually, this ARDS net trial has changed the practice of ventilator management of ARDS, and it showed a significant mortality benefit. Next slide. So this study actually looked at two groups. One group, they ventilated with 6 ml per kg of tidal volume of predicted body weight, and another group was given traditional tidal volume at that point of time, that is 12 ml per kg of predicted body weight, and they compared the outcome in these two groups. And this chart will show that death before the discharge home and breathing without assistance was much better in a low tidal volume ventilator, that is 31%, as compared to almost 40% in traditional or 12 ml per kg of tidal volume. So there's a significant mortality benefit was found in this study, and this study was actually prematurely stopped because the group which are getting low tidal volume showing significant mortality benefit. Next slide. So, what is the problem in management of ARDS, particularly when we are ventilating this patient? This lung is heterogeneically involved, and this lung is called as baby lung. A patient of adult patient, when he is having bilateral involvement of the lung, if you see the normal lung, which is very small as compared like baby lung. So when we are ventilating lung with a XYZ strategy of ventilation, some part of the lung is normal, some part of the lung is edematous, some is consolidated, and some part of the lung is collapsed or attenuated. And we're having applying same pressure or volume to all parts of this lung. So effect of our ventilation is different at different parts, and that will cause either normal lung will get distorted or adverse effect, or some consolidated or arterial lung may become open. So for this baby lung concept, we are actually giving low tidal volume to ventilate the normal lung. We don't want it to push more air or tidal volume to a lung which is consolidated. So that was a concept called as baby lung concept, and this is proved that if we ventilate with low tidal volume, a 6 ml or less than 6 ml of patent body weight, a patient may do better. Next slide. So this concept of low tidal volume ventilation evolved with a lung protective ventilation. After this ARDS net trial published in NHGM 2000, or it is called as ARMA trial, and it has showed significant mortality benefit. So first you have to calculate the predicted body weight, and these are the formulas which are given in most of the books or in the um, most of the app of medical calculation. The mode used in this study was volume control or volume assist control. Initial target is to have 6 ml per kg of predicted body weight, and you have to keep respiratory rate less than 35 and plateau pressure less than 30. So when you are ventilating a patient with a very low tidal volume, there is chance of respiratory acidosis. CO2 is retained and patient may develop respiratory acidosis. To prevent respiratory acidosis, you have to increase the rate. You can increase tidal volume. In such patient, you can gradually increase the respiratory rate to keep your pH near normal. And you should not exceed respiratory rate more than 35. And the plateau pressure, which is calculated, if you see, if you have inspiratory hold button on your ventilator, you hold the inspiration, and the pressure which comes after holding the inspiration is called as plateau pressure. And this plateau pressure actually a marker of alveolar pressure, and if this pressure is more than 30, it causes lung injury. So our target of ventilating this patient is to keep plateau pressure less than 30. So these are the subsequent goals. After this basic setting of lung protective, your goal to keep plateau pressure less than 30. If your plateau pressure is more than or equal to 30, you can decrease the tidal volume by 1 ml per kg, and you can even go to 5 ml or 4 ml of predicted body weight. If your plateau pressure is less than 25 and your tidal volume less than 6 ml, you can increase tidal volume by 1 ml because patient may require too much of sedation or paralysis if you give too much of low tidal volume. And patient may have breath stacking or development of atopy because of high RR and low tidal volume, and or patient may get severe dyspnea. So you can increase tidal volume to 7 to 8 ml per kg of period body weight if your plateau pressure is less than 30. So this is the way we ventilate the patients of ARDS, and with the concept of protecting lung. Uh, Next slide. So what are the problems with low tidal volume ventilation? As I told you, CO2 is retained and patient get hypercapnia or respiratory acidosis. The concept called as permissive hypercapnia, where we allow some CO2 to be on higher side. As long as the pH is less than 7.2, we accept the PCO2 so that you continue to have lung protection. The high RR that is used to maintain the minute ventilation during the low tidal may increase the auto peak. So if you increase the respiratory rate, there is inadequate time for exhalation before next breath comes in, and that will create an intrinsic kind of PEEP or auto PEEP, and which may cause severe intrathoracic pressure, which will lead to decrease in cardiac output and even patient may get collapse. So this auto PEEP is another issue with low tidal volume with high PEEP. Then, because you are ventilating this patient with low tidal volume, high PEEP, with high rate, you require huge amount of sedation and sometimes relaxants. So increase sedation after initiation of low tidal volume. Therefore, increased sedation does not appear to persist, and you have to titrate according to the patient condition. Breath stacking is also manifested by dyssynchrony, and you have to give sedation, anesthesia, or paralysis, a paralytic agent to improve the synchrony between the patient and ventilator. If your frequency of breath stacking is more than 3, you may slightly increase the tidal volume to have better ventilation. Next slide. We'll take the questions at the end of session. Uh, this is another study which I wanted to highlight, that uh, epidemiology in pattern of care and mortality in patient with acute respiratory distress syndrome in intensive care unit in almost 50 countries. Next slide. So, in spite of such a significant data in favor of lung protective ventilation and low tidal volume ventilation, these 50 countries observed that less than two-thirds of the patient with ARDS receive tidal volume of less than 8 ml per kg of body weight. The mean tidal volume was actually given to the ARDS patient is as good as patients with non-ARDS patients. So tidal volume was not even given according to the protocols or guidelines. Plateau pressure was measured only in 40% of the patient of ARDS, and only 83 of these patients received PEEP less than 12. So, in spite of a good amount of data, good amount of suggested guidelines, still the practice is not uh, towards that guidelines. Prone positioning, which is something again is one of the very proven benefit of in ARDS, is used only in 16% of patients with severe ARDS. Next slide. So I was talking about the low tidal volume. With low tidal volume, if you increase the PEEP, uh, then you get much more benefit. So whether tidal volume gives benefit or PEEP gives benefit or both give benefit is a interesting issue. Next slide. But application of PEEP is very important concept in mechanical ventilation. So as I told you, there's a concept called as baby lung. Then there's a called as permissive hypercapnia, where we allow some CO2 with keeping pH around 7.2. And third concept is giving PEEP. And giving PEEP, we actually keep lung open at the end of expiration, and that strategy is called as open lung strategy. So open the lung and keep it open is a concept. So based on these two concepts of low tidal volume and open lung are giving PEEP, this avoid barotrauma, volutrauma as we giving low tidal volume, limiting plateau pressure and preventing atelectotrauma by providing PEEP is sufficient to keep lung open throughout the respiratory cycle. So with repeated opening and closing, uh, we get atelectotrauma, which is prevented by giving good amount of PEEP. Next slide. So PEEP is a counterstone of ARDS management. Again, this has been proved in multiple articles. Next slide. So PEEP in ARDS prevents alveolar collapse during expiration. PEEP decreases mortality by causing higher end expiratory lung volume. So because lung volume is increased, there is an increase in the lung compliance, which is a problem in ARDS. It reduces driving pressure. So if lung compliance is improved, the driving pressure automatically comes down. What are the disadvantages of giving PEEP? Because of it is a positive pressure at the end of expiration, it reduces cardiac output. It increases pulmonary vascular resistance and causes alveolar dead space, which causes increase in CO2. There is some risk of regional overinflation of a normal lung because of the PEEP. The effect of PEEP on mortality is varied in different studies, but mortality was lower with higher PEEP in severe ARDS, 34.1 as compared to 39.1. So if patient is having severe ARDS, the higher PEEP works better. Non-significant trend towards higher mortality with high PEEP in mild ARDS. But in mild ARDS, actually it may not show such a good benefit like severe ARDS. Next slide. So setting up PEEP is a challenge, and there are a lot of ways by which we can set up PEEP. But this is a topic by itself. Some time later we can discuss how to set up PEEP. Next slide. So recommendation about the PEEP titration. Current guidelines concerning moderate to severe ARDS recommend using higher rather than lower PEEP. This recommendation is based on the meta-analysis of individual patient data, and subsequent ancillary analysis of lung safe reported that higher PEEP levels are associated with improved survival. Next slide. So guidelines are unguided on higher PEEP means how much higher. So that you have to titrate at the bedside, looking at a lot of things, and which method to be used for titration of PEEP. This is again a controversial issue. Next slide. So after having said about the low tidal volume, that is 6 ml or less than 6 ml per kg of predicted body weight, then having plateau pressure less than 30, or rate to match a pH of more than 7.2, and PEEP, which is quite adequate for a severe ARDS. And one more strategy is coming up as a driving pressure and targets of oxygenation. Next slide. The driving pressure represented by a ratio between a tidal volume and respiratory compliance, uh, which is easily calculated at bedside by plateau pressure minus PEEP. If your plateau pressure is may 30 and your PEEP is 14, so your driving pressure is 16. Next slide. So again, this paper talks about the airway driving pressure and lung stress in ARDS patient. So at 5 and 15 centimeters of PEEP, patient with higher airway driving pressure presented significant higher lung stress. So if you have higher driving pressure, the lung stress is very high. So lung safe study showed that PEEP, PLAD, PEEP and driving pressure were associated with ARDS prognosis, and driving pressure less than 14 centimeter of water is associated with decreased risk of hospital mortality in patient with moderate to severe ARDS. So keeping driving pressure less than 14 was beneficial, proved in this study. Next slide. So conclusion about the driving pressure, it should be kept between 13 to 15 centimeter water, used in association with low tidal volume, plateau pressure less than 30, and lowest PEEP that can keep oxygenation at an acceptable level. When I'm talking of targets of oxidation, we don't wanted uh, 97 or 99 kind of saturation. In ARDS, we can accept something around 90 plus minus 2 of oxygen saturation, and that is quite sufficient. So, if you have an acceptable saturation, that saturation with almost optimal PIP, you can use as a guide. Next slide. Then I must uh, uh, talk on prone positioning in this management of ARDS talk, because low tidal volume, as I told you that it has been proved that it improves the mortality and ventilatory free days after ARDS net trial. But subsequently, the prone positioning, which doesn't require any big gadget or any high technology, which can be done at any of the ICU, has haven't proven had proven significant improvement in the patient outcome after having severe, moderate to severe ARDS. The same patient which I was talking in my initial slides, H1N1 pneumonia, was prone after intubation in our ICU, and he did extremely well after 3 cycles of proning. Next cycle. This is to just show you that it is possible if your ICU is geared up, your staff is trained to do a proper proning. A lot of videos are available on YouTube how to do a proning of a patient. Next slide. So prone position in ARDS improves the oxygenation, increases the recruitment potential of the lung. It reduces areas of alveolar over distension, thus ensuring homogeneous aeration of the lung and potentially reducing ventilator-induced lung injury. Next slide. So this slide explains how prone improves the oxygenation. So when patient is been prone from supine, if you see this is a patient supine and the basal lung is actually collapsed because of the pressure of the heart, and the perfusion of the this ventral part of the lung is also compromised with heart around. If we do proning, most of the lung is homogeneously aerated, and the most of the blood get better perfusion than the supine position. So that is the mechanism how prone improve the oxygenation and improve the homogeneity of the lung and reduces the ventilator induced lung injury. Next slide. So this is again a landmark trial, that is prone positioning severe ARDS. In this is called as ProSeva trial. In this study, prone position was associated with improved in the mortality at day 28, which is very significant, 16 as compared to 33 in non-proning patient. So p-value was significantly high, and this benefit persisted at even 90 days, 24% as compared to 41%. So this is another intervention with low tidal volume ventilation. The prone position is one of the very, very important intervention which improves the mortality in ARDS patient. Next slide. So international guidelines now recommend that prone position should be instituted early and ideally within 36 hours of meeting this criteria, and should be used alongside of the lung protective ventilation strategy like low tidal volume, optimal P, plate to pressure target less than 30. Remember, prone position is quite risky if your staff is not trained and aware. So it's a teamwork. You have to be very careful in doing patient prone with lot of tubes around, line, endotracheal tube, Foley's catheter, and patient is on a high PFI2. So endotracheal tube can be um, come out. It can cause obstruction. Patient may get pressure sores on the face and mouth or chest. You sometimes may disconnect with venous access. However, prone positioning also requires a lot of resource. It is resource intensive and requires a lot of people to do proning, and should be performed by a trained and experienced team. Remember, it is very possible if you do prone for 2 or 3 patients, at fourth or fifth patient, your team is quite experienced and confident in doing prone positioning. So you require a courage and desire to do proning in your ICU, and it definitely improves survival of the ARDS patients. Next slide. Then some patient, in spite of giving low tidal volume PEEP, 100% FI2, doesn't improve on oxygenation. Or sometimes we do some recruitment maneuvers, which are transient, sustained increase in the transpulmonary pressure, designed to open collapsed airless alveoli. So recruitment maneuver used to open the collapsed lung, and PP used to prevent cyclical collapse as a part of open lung approach in the ventilation. It increases end expiratory lung volume and improves the gas exchange, but still, mortality benefit is not been found with recruitment maneuver. And extremely few cases, we may try recruitment maneuver, keeping eye on the blood pressure. Next slide. So if we do a recruitment maneuver, see lung A is 100%, almost 80 to 90% lung is having collapsed and white lung. If you increase the pressure, the some part of the lung is improved. If you see gradually, almost, and this last D section, the most of the lung is open. So this is the beauty of recruitment maneuver. But you have to remember, it may again cause barotrauma. Patient may develop pneumothorax. Patient may develop severe cardiac collapse. So it should be done extremely carefully, and probably with good experience person should do it. Next slide. Lastly, some patient may require extracorporeal oxidation or extracorporeal carbon dioxide removal. We in our ICU tried a couple of times in last few years, and I think after COVID, many big high ICUs and metros did tried ECMO in few of the patient with severe hypoxemia, and few patients are saved with venovenous ECMO. It is considered as a rescue therapy for patient with severe ARDS due to complications related to it and controversial evidence. So it should not be as a routine we should use, but it should be definitely used in a rescue patients who are not improving with your ventilator strategy. The multicentral CESAR trial compared ECMO with the conventional management of ARDS and showed only 76% received ECMO, but this group had an improvement in primary outcome of quality of life at 6 months. The subsequent Eolia trial showed a signal towards improvement in the mortality. So there are trials coming up showing that ECMO definitely improves the outcome, and it has been suggested that even extracorporeal carbon dioxide removal can manage both hypoxemia and hypercapnia in some respiratory failure patient. Even few centers are doing ECMO on a patient who are on NIV, and being ECMO is very kind of a extracorporeal oxygenation. We really don't ventilate with too much of tidal volume, and so we can protect the lung till it recovers from the medical treatment or primary insult. So ECMO and extracorporeal carbon dioxide removal are optional therapy in some patients, and they may even improve survival. Next slide. Fluid management is again a very important part, whether to give liberal fluids or conservative fluid, but this answer has been clearly um, evident after multiple studies. Patient with ARDS has increased risk of pulmonary edema, and this risk is largely due to increased vascular permeability. So balancing two competing priorities, a tissue perfusion on one side and tissue oxygen on the other side, is often challenging. And the overall goal is to minimize or eliminate positive fluid balance, and keeping lungs tightly on negative side rather than giving liberal fluids is a strategy in ARDS. Next slide. So comparative fluid strategy, there are a lot of studies. This is again a paper from NEGM 2006. Compared with liberal strategy, the conservative strategy had improved oxygenation index, lung injury score, and number of ventilated free days. So my message is to keep lungs slightly on a drier side rather than giving liberal fluid when patient is not having hypovolemia or volume responsiveness. So try to be euvolemic or undervolemic rather than over hydrating these patients. Next slide. So in ARDS patient, positive fluid balance has been associated with prolonged mechanical ventilation, longer ICU and hospital stay, and higher mortality. Fluid management may require different approaches depending on the time course of the ARDS, whether patient is in early ARDS or late phase, and depending on you have to titrate your fluid therapy. The effect of fluid strategy management according to ARDS phenotype remains to be evaluated, and people are now looking for it. Next slide. Lastly, I'm going to have some 3-4 minutes on pharmacological therapies in ARDS. Uh, Next slide. Neuromuscular blocking agents, they are required to have better synchrony. So paralyze skeletal muscles by blocking transmission of nerve impulses at the myoneural junction. They are considered in early cases and severe case of ARDS with deep sedation, invasive mechanical ventilation, and when particularly patient needs proning in first 48 hours. There is no evidence to support use of neuromuscular blocking agent as a routinely and very early. So you have to see whether patients, whether they are prone or whether they are being very ventilated with very high rate and very low tidal volume. This patient initially require neuromuscular blocking agent along with sedation and analgesia. Next slide. So what are the things in favor of neuromuscular blocking agent? They improve thoracopulmonary compliance. They improve functional respiratory capacity. They improve ventilation perfusion ratio, distribution of blood flow to splanchnic vascular beds, recruitment of low compliance areas and PEEP maintenance, uh, adaptation to productive ventilation and anti-inflammatory effects. It prevents patient ventilator asynchrony or distend the high compliance territories, de-recruitment and atelectatic trauma. Biotrauma, inflammation, and pulmonary vascular strain is prevented by these drugs. Oxygen consumption is reduced, and high respiratory efforts are prevented by giving muscle relaxants. It might increase chances of ICU acquired weakness, so patient may remain having muscle weakness and delayed in weaning. That is a risk factor with these drugs. Need for deep sedation before giving muscle relaxant adds to the prolongation of ventilation, and duration of sedation is also increased with use of neuromuscular blocking agents. Next slide. Corticosteroid is another a very controversial issue. It is an anti-inflammatory protein expression and is regulated in the nucleus by activated glucocorticoid receptor, glucocorticoid complex, and thus reducing inflammation. So, as we know that ARDS is basically a lung inflammation. So, theoretically, steroid must be useful. What is the current status about the steroids? It is not approved as a medical treatment guideline with no clear benefit in outcome. According to current research, there could be significant patient benefit and the risk of adverse event is thought to be low. So initially we thought that steroid may cause more damage and more chance of infection, but the recent studies are going in favor of steroid. However, clinical trials, majority of which were carried out before advent of lung protective ventilation strategies, provided controversial results in multiple studies about the steroid. So corticosteroids may be beneficial for certain steroid-responsive illnesses that resembles ARDS, like patient with vasculitis or patient with rheumatoid arthritis with ARDS may benefit from the steroid, but not all patients will benefit from steroids. Next slide. Aspirin, again, we tried as a uh, platelet aggregation inhibitor drug. In ARDS, aspirin reduces pulmonary neutrophil infiltration as well as allow inflammation and injury. It is not approved because of no clear benefit in outcome. Interferons again not approved, no clear benefit. Vitamins been actually recommended a few days back, like vitamin D, vitamin C, but again, no study showed a clear benefit, and it is not been approved as a standard therapy. Next slide. Statins, some patient may have some beneficial effect, but again, it is not approved as a standard therapy and no clear benefit in outcome. In acetylcysteine, as an accident, antioxidant been tried in ARDS but not approved, and there is no clear benefit for N-acetylcysteine. Beta agonist been used very frequently in almost all patients who are ventilated, whether they are ventilated for ARDS or whether they are ventilated for any other reason. But they thought to reduce bronchospasm, airway resistance, and inflammation, as well as improve the alveolar fluid clearance and stimulate alveolar epithelial and endothelial repair, thus benefiting pulmonary mechanics. But again, there is no clear benefit to beta agonist, and it is not approved as a standard therapy. So please don't use drugs which are having no clear benefit and not approved by standard guidelines. Next slide. So lastly, with this uh, slightly extended talk on management of ARDS, I would like to conclude that more than 50 years have passed since the first definition of ARDS, and several trials have been performed. Yet we do not have effective pharmacological therapy. Future of ARDS in the era of precision medicine strives toward the identifying treatable traits and looking for ARDS etiology, physiology, and subphenotypes. Biological markers and multi-omics approach are potentially profitable strategies that may need further investigation. Next slide. So basically, if I wanted to conclude my talk, these are the 10 golden rules set on a ventilator in patient with ARDS. Rule 1 is ventilate with 4 to 6 ml per kg of weighted body weight. Keep your plateau pressure, which is calculated by inspiratory hold button on the ventilator, should be less than 27. Driving pressure, which can be calculated by PEEP, plateau minus PEEP, should be less than 15. Don't keep respirated more than 30 breaths per minute. And the mechanical power is another concept which increases with respiratory rate and will be detrimental to the patient. So try to keep rate as low as possible, keeping your pH near 7.2, but not like 7.3. So you have some permissive hypercapnia. PEEP should be optimal and should be high in moderate to severe ARDS, and you have to consider personalized PEEP depending on the patient's respiratory compliance and patient's phenotyping nature. Keep mechanical pressure less than 17 joules per minute. Consider extracorporeal carbon dioxide removal or ECMO if your mechanical pressure is more than 17 joules per minute. It can be used as a rescue therapy in few of the patients, and patient may be saved with ECMO or extracorporeal oxygen removal. Prone position, of course, a very important intervention, should be done for 12 to 18 hours in a day if your PF ratio is less than 150. Preferably do it in the first 36 hours of ARDS. Early prone helps much better than late proning. Neuromuscular blocking is a 8 rule that is in severe ARDS when appropriate should be used. Rule 9 is recruitment maneuvers can be useful but not routinely recommended because having high risk of barotrauma. And last, that is 10th rule is consider rescue extracorporeal removal of carbon dioxide or ECMO if patient does not improve with all other measures. Next slide. So a patient of ARDS is a real challenge to an intensive care people. It's a teamwork, and I'm happy to have a very dedicated team in my ICU. So we routinely do proning, routinely put arterial lines, routinely manage a patient with severe ARDS with very minimal antibiotics. And the patient which I was talking to you was discharged yesterday on 11th or 12th day of his admission. He was on ventilator for almost 9 days, and last 3 4 days he was not on any antibiotic. He was treated with oseltamivir for initial 7 days. He was on piperacillin-tazobactam for 7 days, and after that 7 days of course, He took some more time to get wind up from the ventilator, and he was treated without antibiotic. And I must appreciate my team that our infection control practices are quite effective to prevent ventilator associated pneumonia or high acquired infections, and we could discharge this patient with minimal morbidity, minimal cost, minimal antibiotics, and the relatives went with very happily happy faces, which relieved our stress of managing ARDS. Lastly, I just wanted to tell you that in MGM MCRI, we started a fellowship course for post MD patient people like MD anesthesia, medicine, chest, and family medicine, emergency medicine, and you can really get good learning experience in our MGM hospital. Thank you so much for your patient listening. Thank you.
Thank you, sir. Thank you so much for contributing that much. And that's a few of the people has raised their hand in between the presentation. So I request them to please raise their questions if they have any query.
Gite Darvi has raised hand, open in queue.